line was an absolute godsend to me. I don't know what I'd do without it.
You probably would have to stay in the hospital, but because I had the Picc line, I didn't. And it was nice because I was home, around my family, not in here.
I'll be honest, I mean, it was less painful than getting a regular IV put in.
It's not uncomfortable at all, and the maintenance is very easy.
A Picc line is a device that allows you to receive IV fluids and medications without the need for multiple needle sticks.
By having a Picc may allow you to go home when you might otherwise have had to stay in a hospital. It requires meticulous care.
A Picc line is much longer than a standard IV line and is inserted under sterile conditions by specially trained nurses or doctors. It can remain in place for weeks.
However, just remember, a Picc line is also a potential route for bacteria to enter the bloodstream, and this bacteria can cause serious infections. That's why the proper care of the line and its dressing is critical.
This video is designed to teach you and your caregiver how to properly and safely care for a Picc line. If you have a home infusion nurse helping you, please consult with the nurse for additional information.
To get you started, you'll be given some supplies to take home. We should point out that the supplies your home infusion company provides may be different from those used in the hospital or shown in this video.
Please view the entire video. Patience is essential. You can't rush the process of caring for your Picc without risking an infection or contamination.
It's important to regularly flush the Picc line. That will help keep it from clogging.
You must flush the line before and after medication is given, before starting and after ending an infusion, and after every 12 hours that the Picc line has not been used. First, we'll show you how to flush before and after medication or an IV infusion is given. You'll use what's called the SASH technique. SASH stands for saline, any infusion, whether a continuous IV or medication, saline, and heparin. The first step is to get your work surface ready. The surface needs to be cleaned with disinfectant wipes before you start. Cover it with a clean paper towel or Chuck's pad. For this procedure, you will need two 10-milliliter pre-filled normal saline syringes, your medication infusion, one pre-filled heparin syringe, alcohol preps or chlorhexidine swabs, a box of clean gloves, and a sharps container. The first step is to wash your hands with soap and water for 30 seconds and dry with a clean paper towel. Or use an alcohol-based hand sanitizer and let air dry. Put on a pair of clean gloves. Now we'll perform the first SASH step, saline. Remove the cap from the saline syringe. Apply gentle pressure on the syringe plunger to push out the air bubble. Clean the end cap, also called a hub, with an alcohol prep or chlorhexidine swab. You must scrub the hub for 30 seconds, allow to air dry. Then, using a clockwise motion, screw the tip of the syringe into the end cap of the catheter. Make sure to unlock the catheter clamp. Once the syringe is securely attached, flush the contents of the syringe through the catheter by using a gentle stop and start motion. You don't want to flush the entire syringe contents in one push. Vigorous flushing will damage the Picc line.
The saline should go into the catheter easily. If it's hard to push the saline in, stop and contact your doctor or home care nurse.
When you are done, unscrew the used syringe from the cap and discard it into the sharps container. Next is any infusion. With another alcohol prep or chlorhexidine swab, scrub the hub again for 30 seconds. Using a clockwise motion, screw in the end of the IV medication tubing. Now start the infusion. Remove your gloves, discard, and wash your hands. Once the infusion is complete, you're ready to perform the second S step, saline. Wash or disinfect your hands and put on clean gloves. Scrub the hub with an alcohol prep or chlorhexidine swab for 30 seconds and allow to air dry. Remove the cap from your second saline syringe. Apply gentle pressure on the syringe plunger to push out the air bubble. Using a clockwise motion, screw the tip of the syringe into the end cap of the catheter. Once the syringe is attached securely, flush the contents of the syringe through the catheter by using a gentle stop and start motion as discussed before. When you're done, unscrew the used syringe and discard it into the sharps container. Scrub the hub again with an alcohol prep or chlorhexidine swab for 30 seconds. This brings us to the final step, H for heparin. Open the packaging containing the pre-filled heparin syringe. Remove the cap from the syringe and push the plunger to release any air bubbles. Twisting clockwise, screw the syringe into the cap. With a gentle stop-start motion, push the contents of the syringe into the catheter. When you're done, twist counterclockwise to unscrew the syringe from the cap and lock the catheter clamp. Discard the syringe in a sharps container. Remove your gloves and wash or disinfect your hands. When a catheter is not in use, it must be flushed every 12 hours with normal saline and then with heparin.
Picc lines can either be single, double, or triple lumen catheters. We will show you how to flush a single lumen Picc. These steps, just remember, must be repeated for the other lumens if you have a double or triple lumen line.
Here's what you'll need for a single lumen Picc. 1 syringe pre-filled with 10 milliliters of normal saline. 1 syringe pre-filled with heparin. Alcohol preps or chlorhexidine swabs. A box of clean gloves. And a sharps container.
If you have multiple lumens, you will need 1 syringe of normal saline and 1 syringe of heparin for each lumen you flush.
First, wash or disinfect your hands. Then put on clean gloves. Open the packages containing your saline and heparin syringes and place them on your work surface. Scrub the hub with an alcohol prep or chlorhexidine swab for 30 seconds. Remove the cap from the normal saline syringe. Apply gentle pressure on the plunger to push out any air bubbles that may be in the tip. Then, using a clockwise motion, screw the tip of the syringe into the end cap of the catheter. Open the catheter clamp. Once you are sure the syringe is attached securely, flush the contents of the syringe through the catheter using a gentle stop-start motion. Unscrew the used syringe from the cap and discard it in a sharps container. Scrub the hub with an alcohol prep or chlorhexidine swab for 30 seconds. Remove the cap from the heparin syringe and push the plunger to release air bubbles. Using a clockwise motion, screw the syringe tip into the cap. With a gentle stop-start motion, push the contents of the syringe into the catheter. Using a counterclockwise motion, unscrew the syringe from the cap and lock the catheter clamp.
Remember, if your Picc line has more than 1 lumen, you must repeat all of these steps for each lumen of your catheter.
Be sure to discard all used syringes in a sharps container, then remove your gloves, and don't forget to wash your hands. Your dressing should be changed every 7 days or whenever the dressing gets soiled, wet, or becomes loose. Before you begin, decide where you want to set up your supplies. This can be a tray, table, or any other flat, stable surface. The surface needs to be cleaned with disinfectant wipes before you start.
The surface you're using should be covered because surfaces can harbor bacteria.
An easy way to do this is with aluminum foil, but be sure to also clean the aluminum foil with a disinfectant wipe and discard the wipe. Before going further, you need to wash your hands with soap and water for 30 seconds and dry with a clean paper towel. Remember, to prevent contaminating your hands, use the paper towel to turn off the faucet. Or if you prefer, use an alcohol-based hand sanitizer and let air dry. Now bring over all the supplies you'll need to change the dressing. These are the dressing kit, a disc containing chlorhexidine which is placed around the catheter site to keep it free of infection. Some dressings already have a chlorhexidine gel built in and are known as chlorhexidine impregnated dressings. A stat lock to secure the Picc line, a Picc line end cap, a box of non-sterile gloves, an extra pair of sterile gloves, several alcohol prep pads, several chlorhexidine swabs, and gauze. There's a special way to open the dressing kit. Because it contains sterile supplies, it's important to open it with the paper side up. On the very top will be a mask. Take it out and put it on. Carefully remove the package of sterile gloves and place it to the side. Next, take out the paper drape and carefully unfold it onto your work surface. This is now your sterile field.
Remember, it's important to open items so that they fall away from you onto the sterile field.
Turn the kit over and allow the remaining supplies to gently fall onto the sterile field. Next, open the end cap package and place its contents onto the sterile field. Open the package containing the disc and place it on the sterile field. Last, open the stat lock package and place its contents onto the sterile field. Now that you have everything you need on hand, take a pair of non-sterile gloves from the box and put them on. Starting from the bottom edge, slowly peel off the old transparent dressing. You may need to moisten the edges with alcohol preps to loosen them. If your dressing already has chlorhexidine built into it, sterile saline should be used to loosen the dressing. Work your way up to the top of the dressing. Once you've removed it completely, throw it into the garbage. Next, unsnap the stat lock. Gently lift out the catheter and place it so that it is resting on the side of the arm. Peel off the stat lock and throw it away.
The next step is very important because you're looking for any signs that the catheter is loose or infected.
Look at the catheter and surrounding skin. If you see swelling, redness, or draining fluid or pus, continue with the dressing change, but call your home care infusion nurse or doctor as soon as you're done. If the catheter seems to be dislodged or more of the tubing is showing than before, continue with the dressing change and then seek immediate medical attention. Now we'll show you how to put on the new dressing. One of the most important things you have to do is to wash or disinfect your hands again. Once your hands are clean, open the package containing the sterile gloves. Be careful to only touch the turned up inside cuff of the first glove as you slip it on. When you're ready, put on the second glove.
Remember, both of your gloves are now sterile, so you have to be careful what you touch.
Open the package containing the chlorhexidine scrub swab stick. Remove the stick, holding it in one hand. With your other hand, pick up a gauze pad from the sterile field. Use the gauze pad to lift the catheter slightly. With a side-to-side motion, clean the skin underneath the catheter with the swab. You want to clean a 4-inch by 4-inch area. Keep swabbing for about 30 seconds. Then make sure to clean the entire catheter. Let the skin air dry. Don't wave your hand or blow on the skin surface to dry it. You might contaminate the area. It may take up to 2 minutes for the skin to air dry. Discard the gauze and swab stick. Do not place these used items back on your sterile field. Your kit may come with a chlorhexidine swab stick that looks a little different, with wings on the sides. With this type of swab, you will need to release the liquid chlorhexidine by squeezing the wings. Then touch the swab against the skin until you see the liquid soaking the sponge end. Now that the area around the catheter is clean and dry, pick up the disc. Open it at the slit and place it sponge side down snugly around the catheter. Next, you must prepare the skin for the new stat lock. A skin prep pad comes with the stat lock package. Use it to wipe the area where you plan to apply the stat lock. Allow the skin to fully dry. While holding the new stat lock, place the wing section of the catheter into the stat lock and snap both sides closed. Next, peel off the paper backing and place the stat lock on the prepped area. You're now ready to put on the new dressing. Peel off the paper backing. Hold the dressing so that the V notch is opposite the insertion site. Place it on the arm covering both the biodisc and the stat lock. With one hand, peel off the outer paper cover while sealing the edges of the dressing with your other hand.
At Continuum hospitals, we don't need to use the disc because the chlorhexidine is already built into the dressing. As we've already mentioned, your home care agency may provide you with supplies that are different from those used in the hospital.
You're now ready to change the end caps. This needs to be done every time the dressing is changed, if the caps leak or are damaged, or each time a nutrition bag is started. Before starting, clean your hands with soap and water or use an alcohol-based hand sanitizer. Then take a pair of non-sterile gloves from the box and put them on.
The procedure for changing the end caps is similar to the one you use to flush the catheter.
Remove the cap from the saline syringe. Remember that if this is being done immediately after your dressing change, the cap package will already have been opened and the cap will be on your sterile field. Open the package containing the cap. Using a clockwise motion, without touching the blue top, screw the tip of a normal saline syringe into the end cap. Gently push on the syringe to remove the small amount of air that may be trapped in the cap. Leave the syringe attached to the cap. Squeeze closed the clamp on each catheter. You should hear and feel a click. Twist off the old cap by turning it counterclockwise and discard. Wipe the end of the catheter with an alcohol prep or chlorhexidine swab for 30 seconds. Allow to air dry. Remove the protective cover from the new cap by twisting it. Attach the new end cap. Open the catheter clamp. Flush the catheter with the normal saline remaining in the attached syringe. Close the clamp. Disconnect the syringe and discard in the sharps container.
Just remember now, if your PICC line has more than one lumen, you must repeat all of these steps for each lumen of your catheter.
It is very important to keep the PICC line dressing dry and intact. Do not take a tub bath, go into a hot tub, or go swimming. You can take a shower if you protect your PICC line with products such as Press and Seal or a shower sleeve. If you use Press and Seal, make sure to wrap the arm so that the PICC line site is completely covered. Make sure to press the edges so that the plastic seals. This will keep your dressing and the site dry. When in the shower, keep your arm with the PICC line up in the air and away from the water to prevent the PICC line from getting wet. Towel dry completely before removing the Press and Seal from your arm. If the dressing appears wet or has become loose after the shower, change the dressing using the sterile technique described in this video.
Sometimes, even if you have done everything correctly, problems can occur. If you have any of the following conditions, contact your doctor or home care service provider or go to the emergency room.
Fever, pain in the PICC line arm, bright red blood under the PICC line dressing, redness, tenderness, or swelling in the arm with the PICC line or at the PICC line site. Other times to call your doctor or home care service provider or go to the emergency room include a tear or break in the PICC line, leaking of IV fluid or medication from around the PICC line insertion site. You cannot flush the PICC line. More length of the PICC line catheter is visible, or the line seems to have pulled out partially or completely.
Honestly, you just have to know how to follow directions. That's it. Just follow the directions. It's just so simple. It is.
It only takes a couple of minutes. You know, my husband was even there, and he when they showed him the first time, he picked it up right away. And I picked it up right away. It's not that hard.
I wasn't able to go back and bench press the gym and some things like that. But again, compared to lying in a hospital bed, I was able to be much more active and do a lot more things.
If I can do it, anybody can do it.
We put the medicine in her PICC line. I think it can help my mother feel better. Because she's got to be healthy and strong.
Accessing a Port by Pamela Docks. Introduction.
Hi, I'm Pam Docks, and I'm a nurse on the oncology unit at Boston Children's Hospital. Today, I will be talking about portacaths, which are a type of central venous access device. I will review the equipment needed to access the port, give a demonstration of how to access the port, and review post-procedure care. A venous access device, or portacath, is designed to permit repeat access to the central venous system without the presence of an external catheter. The portacath is implanted subcutaneously, usually along the anterior chest wall, although other sites may be used. It is sutured to the muscle fascia.
Catheter conformation and use.
The initial placement of the venous access device catheter tip is confirmed by radiographic exam. Catheter tip location is verified prior to use for patients with a previously placed venous access device. The patient's history and assessment should include current catheter function, a thorough assessment of catheter dysfunction, and if your medical record confirmation of the catheter tip placement is not available, a radiographic confirmation will be obtained prior to using the device.
Equipment.
In order to access a portacath, you will need the following things: a central venous catheter dressing tray, which includes sterile latex-free gloves, a mask, chlorhexidine sponge, a 4x4 gauze, an occlusive dressing, and tape. Other items you will need are a right-angle non-coring needle, topical anesthetic such as Emla or Elamax, a needleless connector, and a 10 cc sterile normal saline syringe.
Procedure.
Whenever possible, use topical anesthetic prior to access. Explain the procedure to the patient and/or their parent to promote understanding and cooperation. Clean off the bedside surface you will be working on to prevent the spread of infection. You may want to ask your patient to lie down during the access, as this makes it easier to stabilize the port. However, some patients may choose to sit up during the access. Open the central venous access dressing tray and don a mask. Perform hand hygiene, including a 30-second hand wash. Open your sterile field. Open your sterile non-coring needle set, 10 ml sterile normal saline syringe, and needleless connector onto the sterile field. Don sterile gloves. Attach the needleless connector to the needle set and prime with sterile normal saline. Close the clamp and return it to your sterile field. Be sure to check your institution's policy in regards to which antiseptic agent should be used to cleanse the skin prior to accessing the port. Cleanse the skin with ChloraPrep cleaning solution per your institution policy. Utilize a 30-second scrub in a back and forth and up and down motion, including the entire area where your dressing will adhere. Palpate the area of the implanted port with your non-dominant hand, locating the center of the port's septum. Rotate the site with each access. Do not use the same hole for each access, as it will lead to skin breakdown. With your dominant hand, firmly push the needle perpendicularly through the skin into the device until the needle meets the bottom of the device. It is important that there be a small space between the needle and the skin line. If flush with the skin, the needle length is too short and there is an increased risk of infiltration. If necessary, support the space between the needle and the skin with a folded 2x2 gauze to prevent rocking of the needle, which can cause damage to the septum and irritate the skin. Gently flush with 3 to 10 ml of normal saline or aspirate for blood return to verify proper placement. Apply an occlusive dressing. If necessary, cover the wings of the extension set with a folded 2x2 gauze to prevent inadvertent removal of the needle when taking off the occlusive dressing. Of note, gauze placement is often used for short-term portacath access to stabilize the needle. If needed in place for a longer period of time for continued needle stabilization, please review your institution's infection control policy regarding how often to change the gauze, as it can be a medium for bacterial growth. Apply tape around the tubing where it exits the dressing to ensure occlusiveness. Unclamp the extension tubing and gently flush with 3 to 10 ml of normal saline and connect to your administration set. Date and initial your dressing. If you are not connecting to an IV infusion, scrub the cap with alcohol for a minimum of 15 seconds and allow to completely dry. Flush with 5 ml of heparin, 10 units per ml, and disconnect the syringe and clamp the set. Secure the portacath to the patient at a second site by taping to the skin or pinning to the clothing to prevent tension on the tubing and needle, which can cause an inadvertent dislodgement. Document the needle and dressing change in your patient's chart.
Post-procedure catheter care.
Some other important information about portacaths. Change the dressing when the non-coring needle is changed or if the dressing becomes loose or soiled. The dressing should remain occlusive at all times. Use only non-coring needle sets right angle. These are available in various lengths depending on the size of the patient. Change the non-coring needle a minimum of every 7 days. The needle may need to be changed if you experience difficulty flushing or if you are unable to obtain blood return. This concludes our video on accessing a port. Thank you for watching.
Please help us improve the content by providing us with some feedback.
Central venous access device, dressing change. Before beginning this procedure, always perform the following steps to ensure patient safety. Perform hand hygiene. Provide patient privacy. Introduce yourself. Use 2 patient identifiers. Verify allergy status. Perform environmental safety check. Ensure proper body mechanics. Gather all supplies. Provide patient education. Materials needed for CVAD dressing change. Mask. Dressing change kit. Transparent dressing. BioPatch. ChloraPrep. Skin prep. Sterile gloves. Assemble supplies before entering patient's room. The procedure. Don clean gloves and mask. Ask patient to turn head away from insertion site. Provide patient with a mask. Inspect and palpate site around dressing for swelling or tenderness. Remove dressing by pulling it towards catheter's insertion site. Remove antimicrobial patch. Measure external portion of catheter. Compare previous length to what was previously documented to detect migration. Discard dressing and gloves. Perform hand hygiene. Open sterile dressing kit and don sterile gloves. Cleanse insertion site. First, must physically cleanse with alcohol in a circular motion for at least 30 seconds. Be cautious not to tug the line and cause the line to dislodge. Do not cross sterile field. Then, must physically cleanse skin with CHG swab under central line in a back and forth motion for 30 seconds. Must physically cleanse the central line with a new CHG swab from insertion site upwards. Allow to air dry. Apply skin prep. Apply antimicrobial patch, BioPatch. Apply transparent dressing. Coil external portion of catheter and tape in place. Label new dressing with date, time, and initials. Dispose of soiled supplies in biohazard bag. Return bed to appropriate height, brakes locked, appropriate side rails up, and call light within reach. Dispose of trash in proper receptacle. Wash hands per CDC guidelines.
How to change the dressing of your peripherally inserted central catheter, also called a Picc. In this video you will learn what is a Picc and why you may need one, and how to change the dressing of your Picc. What is a Picc and why you may need one? Your healthcare team will suggest a Picc if you need IV therapy. Having a Picc means you do not need to have a needle put into your arm each time you get fluids, medicines like chemotherapy and antibiotics, a blood transfusion, IV nutrients, food, blood samples taken. A peripherally inserted central catheter is used to deliver medications and other treatments directly to the large central veins near your heart. A Picc is a small flexible tube placed into a vein in your upper arm. One end of the tube goes inside your body, the other end stays on the outside. Your Picc has several parts. Exit site. The exit site is where the Picc is inserted. The exit site must be covered with a dressing called Tegaderm to prevent infection. Your healthcare team will not use stitches to keep your Picc in place because stitches increases the chance of infection. To prevent your Picc from slipping out, a securement device is used. StatLock is a type of securement device. You may be using a different brand when changing the dressing of your Picc. This securement device must be changed when your Picc dressing is changed. Your Picc may have 1, 2, or 3 tubes that come out of your skin. These tubes are called lumens. Having more than one lumen means your nurse can give you different IV therapies at the same time. The clamp stops blood from coming out of the Picc. The clamp has to stay closed when the lumen is not in use or when the lumen cap is being changed. The lumen cap. A cap closes the end of each lumen opening, stops blood from coming out of the lumen, stops germs from entering the Picc, and helps attach IV tubing and syringes safely. This video will show you how to change your Picc dressing at home. You will need the help of a caregiver or family member to change the dressing of your Picc. How to change the dressing of your Picc. A dressing is a special covering used to protect the Picc exit site. The dressing blocks germs and keeps the exit site clean. If the dressing is loose, gets wet, or dirty, germs can get in the area around the exit site and cause an infection. The dressing of your Picc should be changed once a week and sooner if it is visibly soiled, loosened, or if there is redness at the site. Here are a few things to remember. Avoid getting your Picc wet. Do not put your Picc under water. You can shower with your Picc if you cover your Picc with plastic wrap so water does not get through. Make sure your Picc stays dry. If it is wet after you shower, you will have to change the dressing of your Picc. Remember to work gently with the Picc as the area may be sensitive and the Picc can easily be pulled out of the exit site. There are 5 main steps you must take to change the Picc dressing. Step 1. Gather your supplies. Step 2. Prepare a clean work area. Step 3. Remove the old dressing. Step 4. Clean the exit site area. Step 5. Apply the new dressing. Step 1. Gather your supplies. You will need clean disposable gloves, sterile gloves, face mask, 2 chlorhexidine CHG swabs, alcohol swabs, medical tape, a StatLock package. A StatLock package contains a StatLock Cavalon, which protects the skin from dryness and itchy skin, and sterile tape, and a Tegaderm dressing. Ask your healthcare team where you can get these supplies. If you are allergic to any of the products, your healthcare team will give you a different product to use. Step 2. Prepare a clean work area. Before you open your supplies, find a clean, dry area. Do not change the Picc dressing in a damp area like the bathroom, as this can cause an infection. Instead, choose somewhere dry like your living room or dining room. Clean the work surface with a disinfectant wipe or with soap and warm water. Remove all your jewelry from your fingers and wrists. Wash your hands with soap and warm water for 30 seconds. Dry your hands with a clean paper towel. Put on a face mask and a clean pair of gloves. You will need to wear a face mask as breathing or coughing on the exit site can cause an infection. Once you have done this, you are ready to remove the old dressing. Step 3. Remove the old dressing. To remove the Tegaderm dressing, slowly loosen the edges of the dressing. Hold on to the bottom part of the Picc with one hand to prevent the Picc from moving. Gently remove the dressing from bottom to top. Keep the dressing close to the skin and remove the dressing slowly. Do not stretch or pull the dressing as this can cause small skin tears. Once the dressing is removed, look at the exit site for signs of infection such as redness. Redness at the site may look different on different skin tones. If you cannot see the color around the site but have signs of infection like blisters, itching, clear fluid or pus, white or yellowish leaking, pain, swelling, or warmth at the exit site, fever, contact your healthcare team as soon as you can. You will still need to complete the dressing change. After you remove the old dressing, you can remove the stat lock. Place a piece of tape on the lower part of the Picc. This prevents your Picc from coming out while you replace the stat lock. Use an alcohol swab to loosen the glue underneath the stat lock. Lift the stat lock gently from the skin. Lift the Picc and stat lock from the skin. Lift each of the stat lock tabs. You will hear a clicking sound. Throw the stat lock in the garbage. Check to see if your Picc has moved. This can be done by counting the black dots on your Picc if they can be seen. The number of dots showing on the outside of your Picc should be the same as the last time you changed your dressing. You will write down the number of dots you see on a piece of tape when you have finished changing the dressing. Let your healthcare provider know if your Picc has moved by 3 or more dots. If it has moved by 3 or more dots, you must still complete the dressing change. Step 4. Clean the exit site area. You must clean the exit site with special swabs called chlorhexidine gluconate or CHG swabs. CHG swabs help to clean your skin of any germs. For demonstration purposes only, the exit site in this video is under the sleeve. Remember to not touch the Picc exit site with your hands. To clean the exit site area, open the first chlorhexidine CHG swab. Scrub the Picc exit site with the CHG swab. To clean the exit site and the skin around the exit site, follow the pattern shown in this animation. It is important to clean the area horizontally for 15 seconds. Turn the CHG swab over to the unused side and continue cleaning the skin vertically for another 15 seconds. Remember, for demonstration purposes, the exit site is under the sleeve. However, when you are changing the dressing of your Picc, the exit site will be near the red circle shown on screen. Throw the used CHG swab in the garbage and open a new CHG swab. Clean the Picc with CHG from top to bottom. Make sure to clean on top of and underneath the Picc. Always move the swab in the direction away from the exit site to prevent infection. Allow the CHG to dry fully. This should take 30 seconds to a minute. You can now remove and throw out the disposable gloves and any used supplies. If the CHG is not fully dry, it can irritate your skin and cause blisters. Do not blow, fan, or use a hairdryer on the site as this can blow germs on the area and cause an infection. Do not touch any part that has been cleaned. If you do, clean it again with another CHG swab. Step 5. Apply the new dressing. You will need to do these 4 things when applying the new dressing. Prepare your supplies and put on a new pair of sterile gloves. Apply the Cavalon. Apply the stat lock. Apply the Tegaderm dressing. Do this carefully, as touching any of the supplies without wearing sterile gloves can cause harmful germs to get on the supplies and cause infection. Before opening the sterile gloves packaging, remember to use hand sanitizer on your hands for 30 seconds. Once you have cleaned your hands with hand sanitizer, open the sterile gloves packaging. Do not touch the inside of the packaging, as it is sterile or free from germs. Touching the sterile area can introduce germs which can cause an infection. Open the stat lock package. Empty the stat lock and Tegaderm packages onto the sterile gloves. Do not touch any supplies until you put on the sterile gloves. Pick up one of the sterile gloves from the opening end of the glove. Carefully put the sterile glove on without touching the hand part of the glove. Repeat with the other hand. Once you are wearing the sterile gloves, you can touch the stat lock, sterile tape, and Cavalon. Apply the Cavalon. First, apply sterile tape between the Picc exit site and the area where the stat lock will go. This helps to keep your Picc in place. Open the Cavalon package. Apply the Cavalon over an area large enough to cover the entire dressing, but do not apply the Cavalon directly to the exit site. Once you have wiped the area with Cavalon, let it air dry until the skin is no longer wet. This should take about 30 seconds to a minute. Do not blow or fan the area, as this can cause an infection. You have now applied the Cavalon. The stat lock has arrows on both sides that point up toward the patient's head. The arrows help in placing the stat lock in the correct direction. Once you have the stat lock ready, put one wing of the Picc onto a blue spike on the stat lock. Here is an illustration applying the stat lock. Then close the clear lid. You will hear a clicking sound. Repeat the steps with the other wing of the Picc. Peel off the paper backing of the stat lock and place the sticky part to the skin one wing at a time. Remove the sterile tape that is holding the Picc in place. You have now finished applying the stat lock. Next, apply the Tegaderm dressing. Remove the backing of the Tegaderm dressing. Place the Tegaderm loosely over the exit site and stat lock. Make sure you can see the exit site through the clear part of the dressing. Here is an illustration that shows where the Tegaderm dressing will be placed. Do not put the Tegaderm dressing too tightly on your skin. Remember, for demonstration purposes, the exit site in this video is under the sleeve. When you change the dressing of your Picc exit site will be under the Tegaderm, as shown here. You can now remove the paper film on the top of the Tegaderm. The large secure tape also includes the sticker that you will need to write down the date the Picc was changed. You will need this piece of tape in a few minutes. Place the large secure tape over the bottom edge of the Tegaderm. These two pieces have a U-like shape. The two pieces have to line up with each other and with the Picc line underneath. If it is not lined up, you can lift the tape and apply it again. You do not need a new dressing. On the date label sticker, write the date the dressing was changed and a number of dots showing. Apply the tape with the date along the white border of the dressing. You have now applied the Tegaderm dressing and are finished changing your Picc dressing. Once you have finished changing the dressing of your Picc, place all used supplies in a regular garbage bin. If you have any questions or concerns, contact your healthcare team. For more information about Picc lines, read the pamphlet, peripherally inserted central venous catheter. Remember to read the pamphlet before or as you are watching this video. You can find the pamphlet at the Patient and Family Library located inside the Princess Margaret Cancer Center, online, or by asking your healthcare team. If you are a patient of Princess Margaret Cancer Center, your nurse will give you the information on who to contact if you have any questions. If you are a patient of Toronto General, Toronto Western, or Toronto Rehab Institute, call your home care nurse or coordinator. In this video, you have learned what is a Picc and why you may need one, how to change the dressing of your Picc.
Most patients that walk into a hospital will eventually have an IV placed. This is a task that can be completed by PCTs and nurses. There's a lot of skill and knowledge involved in the placement of IV catheters, and this video will demonstrate and explain the basics of placing an IV using the Insight AutoGuard needle from BD. This information will set you up for success, and once you're armed with that information, it will then be your responsibility to practice and hone your skills until placing IVs becomes second nature. When does a patient need an IV? In the past, the policy at Trinity Health Livonia was that all patients required IV access, but that's no longer the case. Since the implementation of the vascular access team and the availability of ultrasound-placed IVs and intraosseous access, it is always possible to quickly attain vascular access in the event of an emergency. So now, IV access is only required for patients that are receiving treatment through that device. IVs are used for things such as continuous fluid infusions, medication infusions, IV push medications, receiving contrast for imaging testing, or for continued access for blood samples. If your patient requires any of these measures, or anything else that utilizes IV access, they will likely require an IV to be in place. Peripheral IVs can be placed by PCTs and RNs. The vascular access team is also available to aid in placement, but they should be called only after multiple unit staff members have attempted to place a peripheral IV. The vascular access team is to be utilized to place the difficult IVs, not all IVs. Once you've identified that the patient will require a peripheral IV, supplies will need to be gathered from the pod room. You will need a transparent dressing. The best dressing we have available is the Tegaderm IV Advance, which also functions as a securement device to protect from accidental removals and displacements. But the basic small clear Tegaderm is also available in the pod rooms. A blue procedural pad. An appropriately sized IV catheter. Clean gloves. A tourniquet. Tape. A chlorhexidine swab, or if that is not available, alcohol prep pads, sterilely packaged 2x2 gauze, a swab cap, extension tubing, and 2 saline flushes. Before you begin, you should understand the supplies. The catheter used at Trinity Health Livonia is the Insight AutoGuard by BD. It is stocked in 3 common sizes. The size is printed on the package, but they are also color-coded. Blue is a 22 gauge, pink is 20, and green is an 18 gauge. The larger the number, the smaller the diameter of the catheter. So the 22 gauge is the smallest diameter, and the 18 gauge is the largest diameter. The AutoGuard is packaged with a protective cover over the needle. Remove it to reveal the needle, a white button, and the grip area of the device. I hold the catheter with my middle finger and my thumb, and place the end of the device against my palm to stabilize the needle while placing. This is my technique, but there is no right way to hold the needle. Find what works best for you. The needle is hollow and beveled. This means that the tip is cut at an angle, resulting in one side being longer and providing the sharp point, and the other side that extends the angle is the bevel. Whenever inserting an IV, the needle must be bevel up. The point should be on the bottom and the angle on the top. This is easily achieved if you look at the white button on the handle. The white button is in line with the bevel, so if the button is on the top, the needle is positioned bevel up. The catheter itself is not the needle. It is over the needle. It is a flexible tubing attached to the colored hub. This is what will remain in the patient after placement. The actual needle will be removed. Because these are 2 separate pieces, it is important to make sure the catheter is properly seated on the needle before poking the patient. The company recommends you rotate the catheter around the needle until you feel it seat into place. When it is in the correct position, you can see a small raised ledge on the top of the catheter hub. This should be on the top of the catheter, and you will use it to thread the catheter off the needle once you've accessed the vein. And finally, there is the white button. This is how you activate the needle retraction. It is a safety feature to protect from accidental needle sticks. Once the catheter is in place in the vein, you will press the white button, and the needle will be instantly pulled back into the handle of the device. Now that you have your supplies, you will need to locate a good site to access. And to set yourself up to find the best site, you want to engorge those veins with blood so that they are easy to see and feel. Do this by first placing the tourniquet. Tourniquets should be reasonably tight. They need to impede the flow of blood so that the veins swell slightly. To place the tourniquet, slide it under the patient's arm, then stretch it up and cross the two sides. Hold them together with one hand, and with your other pointer finger, push the middle of one of the ends of the tourniquet under the part that is squeezing the arm. Do not put the tail end of the tourniquet under, because that will be difficult to remove. What we want to do is to create a slip knot that is easily undone by pulling on one of the tails. So when you are done, both tails should be pointing in the same direction from the tourniquet. Pointing in the opposite direction should only be the loop. The tourniquet should be tight, not so tight as to cause pain, but it should be slightly uncomfortable. If they can't feel it, it probably isn't doing its job. It is acceptable to tie the tourniquet over the sleeve of the gown so that the rubber material doesn't pinch the skin, but this is clinician and patient preference. A tourniquet should only be in place for 1 minute or less. If after a minute you have not located a vessel, untie the tourniquet. You can check the other arm at this point, or wait 1 to 2 minutes before retying the tourniquet to continue looking on that arm. If tied correctly, the tourniquet is easily removed. Just pull on the tail end that created the slip knot loop, and the knot will release, effectively popping the tourniquet off. With the veins swelling with blood, locate a site. There are 2 main strategies for site location. Some people look for veins, as in with their eyes. Sometimes veins will bulge out of the skin and you can see them easily, and other times people will look for the bluish tinged outline of a vein beneath the skin. Others will look for a vein with their fingers, gently running their fingers over the patient's arm to feel the vessels. Vessels will feel like a slight bump in the arm, and if you press on it, the vein should be spongy and rebound to its original shape after you release pressure. If the bump you feel is hard, it could be a tendon or ligament, or it could be a vein that has developed a lot of scar tissue. Even if it is a vein, this is not an ideal site. Veins with scar tissue will be more difficult to access, and their integrity is already compromised from previous damage. Find a location that gives that spongy feeling, and you'll be more likely to have a successful, long-lasting IV. Also keep in mind, people's bodies are generally built the same way. There will be variations from person to person, but the main veins are going to be in the same general location for each person. You can look at mapped out pictures showing all the names and locations, but through practice you will probably find your favorite veins. What are you looking for in a vein? A good vein is important. Larger is better, and you'll need a stretch of vein that is straight for the length of your catheter. The catheter won't be able to bend around corners in a vein, so you need to choose a location that allows for it to slide completely in and remain straight. So where are the best places to place an IV? You've probably seen a lot of IVs placed in the AC. This is inside the bend of the elbow. There's a nice big vein here, and that's why it's always a very common placement, but it is not ideal for a patient laying in bed all day. It's uncomfortable, and every time the patient bends the elbow, it will kink the catheter and impede the flow of fluid or medication through the IV. In general, try to avoid placing IVs in joints for this reason, so wrists shouldn't be a first choice either. Another reason wrists are not ideal is the presence of nerves, tendons, ligaments, etc. On the underside of the wrist is usually a very visible vein, but this location tends to be problematic and painful because of the joint and the pressure the catheter can put on the other structures in this area. But if you trace that vein further up the arm, you may find a much better site. There are usually some visible veins in the hand, and while these are good for lab draws, they aren't ideal for IV placement. Even if you successfully avoid being near any knuckles or wrist joints, it will still likely have issues. People use their hands for a lot of things, meaning lots of movement. More movement means more likelihood of the IV being dislodged. Also, because of where hands go, they get dirty really easily, which increases the risk for infection. And they tend to be more sensitive and painful in general, so hands aren't a first choice for placement either. Arguably, the best locations are in the forearm. There are plenty of large, straight veins and no joints. Do a thorough search for veins in the forearm. Look on the top, look on the bottom, and move the arm around at different angles, and you may reveal some excellent untapped veins. While forearms are arguably the best option, the other sites mentioned are also viable options for placement. But as discussed, they come with more potential drawbacks and issues, so choose your locations carefully. If you don't see something you feel like you can successfully place on the first arm, look on the other arm. Take your time. The biggest mistake people make when placing an IV is rushing while looking for their right vein. If you take your time and find the best vein, your chances of success will skyrocket. Once you've located a site, find a way to mark it. or make note of where the vessel is. You can use a sterile body marking pin to trace the vessel, or use freckles, moles, scars, or other landmarks to remember the location. Because after the site is found, you need to remove that tourniquet, and you may lose visualization of the vessel. In some cases, you will be able to look on either arm to find the best site, wherever it may be. But with a lot of patients, there will be some limitations to where you can place an IV. If a patient has had lymphedema in the past or breast surgery with lymph node removal, you cannot place an IV in the affected arm. If the patient is a dialysis patient with an AV fistula in an arm, you cannot place an IV in that arm. If the patient is a renal patient in any respect, even if they are not currently requiring dialysis, avoid placing IVs in the AC. If the vessels in this area are damaged from numerous IV placements and lab draws, it can cause significant problems if they need to place an AV fistula for dialysis access in the future, and that could be the difference between life and death for a renal patient. Only the vascular access team is allowed to place IVs in the lower limbs. If the upper limbs are unusable, there are many factors that will come into play to choose a different access device or potentially place a peripheral IV in the legs or feet, and the vascular access team will assess the patient's needs in these cases. Be aware of these and any other limitations to site selection that your patient may have before accessing a vessel. Once you've located an appropriate site for your patient's needs, choose the correct gauge needle. As previously stated, 22 gauge, 20 gauge, and 18 gauge catheters are commonly stocked in the unit pod rooms. 22 gauge is the smallest and 18 gauge is the largest. There are a few factors that come into play. The larger the catheter diameter, the faster fluids or medication can be delivered into the vein. Smaller diameter catheters will restrict the speed of delivery. Also take into account the size of the vessel in which you will be placing the catheter. In general, the further down the arm, the smaller the vessel. Smaller vessels mean less blood flows through the vein every minute, and flowing blood is what carries the fluids or medication back to the heart to be dispersed through the body. When you insert a catheter into a vessel, it will occlude part of that vessel, but you still need blood to be able to flow through the vein to carry that treatment to the heart. There is a common misconception that bigger catheters are always better, but bigger catheters will occlude more of the vessel, and if the vessel can't handle that size, blood flow could be severely impacted, along with medication delivery. For most general treatments for adults, 22 gauge or 20 gauge catheters will be appropriate and result in less vessel occlusion. 18 gauge is only really necessary with large volumes of fluid or medication that must be infused at rapid rates. Also, the larger the catheter, the more damage will be done to the vessel, and the less likely your IV is going to last. So to give your IV the best shot at lasting a long time, a good principle to follow is to insert the smallest gauge necessary for treatment into the largest vein available. With your site and catheter chosen, it's time to get to work. Use the chlorhexidine swab to clean the site. Chlorhexidine swabs can clean 1 square inch for every milliliter of fluid in the swab. This swab holds 1.5 milliliters, so it only disinfects 1.5 square inches, which means you clean your site, not the entire arm, with this swab. Disinfect by vigorously scrubbing the site back and forth for 30 seconds. Then you need to allow time for the CHG to fully dry. This gives you time to set up the rest of your supplies. Open the Tegaderm package, but don't do anything else with the dressing just yet. Open your sterile 2x2s and make them easily accessible. Open the catheter and the swab cap as well. Then take a look at the extension tubing. On one end is the adapter that will insert into the catheter hub, and on the other end is the needleless port that you would insert a syringe into if you were administering something through the IV. Open the package from this end, but don't open it completely. And don't remove the tubing, just expose the port. Then attach a saline flush and prime the tubing. We keep the tubing in the package so that it can act as a reservoir for the extra saline you push out the end as you prime. Keep the tubing in the package for now, to protect it from unnecessary contamination, and lay it with the other supplies. Return to your patient. Ensure the site is dry before continuing. If it isn't, it can lead to increased pain with insertion, and if the dressing is placed over chlorhexidine that isn't dry, it can cause a painful, itchy rash to develop. If the site is dry, retie the tourniquet. The area that you disinfected is now a no-touch zone. You cannot touch this area, or it will become contaminated and you will need to disinfect it again before inserting the catheter. You can touch above or below the disinfected area, though. You can anchor the vessel in place by putting downward pressure on the vessel below the disinfected area. This can keep the vessel from rolling when you insert the needle. Always insert IVs aiming up the arm, never down toward the hand. Inserting down the arm leads to increased risk of clot formation, as well as poor delivery of medication from the catheter. Take the catheter and angle the needle about 15 to 30 degrees to the patient's skin. Any steeper and you will likely poke through the opposite side of the vessel very quickly. Any shallower, and the point of the needle may not be able to enter the vessel. Line the catheter up with the vessel. Poke the patient. As soon as the needle enters the vessel, you will notice blood filling the handle, and probably also the catheter itself. But with some gauges, the blood isn't visible in the catheter. This blood is called the flash. When you see the flash, it means that the needle has entered the vessel. Stop inserting when you see the flash. Take a breath. The first big step is done. Next, you need to ensure that the catheter itself has also entered the vessel. The needle extends further than the catheter, so the flash will come before the catheter is actually in the vessel. You'll need to advance the needle and catheter a bit further, but before you do that, adjust the entry angle. Lower the catheter angle to become closer to parallel with the vessel. When you slide the catheter off of the needle, you want it to be able to slide in along the length of the vessel. If the entry angle is too steep, the catheter may get stuck on the opposite wall of the vessel as you try to thread it in, and this will impede the insertion. With the angle adjusted, just advance the needle another 1 to 2 millimeters. Then stop again. Now the catheter should be solidly inside of the vessel. Next, we are going to advance the catheter off of the needle and into the vein. And if you don't have the catheter in the vein already when you do this, you could damage the vessel as you forcefully push the catheter in, and that can cause the vein to leak, leading to hematoma and an unusable IV. So make sure not to slide the catheter off of the needle until after you have advanced the 1 to 2 millimeters after seeing the flash. Remember that small raised ledge on the catheter hub? Use your pointer finger and push the hub off of the needle using that ledge for leverage. While you are doing this, hold the needle steady. You are not advancing the needle, only sliding the catheter off of it. The needle provides a rigid structure to guide the catheter into the vein. A common mistake is for people to retract the needle after they have the catheter trip in the vein. But when you do that, the rigid guide is lost, and you will have issues if you try to push the flexible catheter into the vein at that point. Another common mistake is to advance the needle with the catheter all the way. When you do this, you will most likely poke through the bottom of the vein. Now the IV is not usable because it's not inside the vessel. You will see no blood return, and if the IV flushes at all, it will cause a lump to form, because the fluid isn't traveling in the vein, it's being deposited in the subcutaneous tissue. When you appropriately guide the catheter off of the needle, you will likely see blood start to exit the catheter. Grab the 2x2s and slide them under the hub to minimize the mess. Then push the white button on the catheter to retract the needle. You do not need to remove the needle from the catheter first. You should push the button while the needle is still inside of the catheter. Once that needle enters the arm, there is no reason you should ever see the tip of the needle again. Retracting the needle at this point eliminates any risk of an accidental needle poke with a dirty needle. Then take the primed extension tubing. There is a white cap on the end of the tubing. Remove it and attach the tubing to the catheter hub. Twist it clockwise to tighten it over the hub. Remove the tourniquet. Pull back on the syringe to check for blood return. You should get blood return. It means that your catheter is still located in the vein. Then flush the blood back into the IV. You want to clear all blood from the tubing. If you accidentally pulled blood into the syringe, grab that second saline flush and flush with a clean syringe of saline. That way you won't be flushing with a mix of saline and blood, and you can be sure that your line is clear when you are finished. Remove the 2x2s. There will probably still be blood on the arm, and do your best at this point to clean that up before applying the dressing to the IV. The Tegaderm IV Advance is available in the pod rooms at Trinity Health Livonia. It functions not only as a line dressing, but also as a very effective securement device to protect against accidental dislodgement or removal. It can be used on all forms of vascular access devices. The dressing consists of 3 parts. They are nicknamed the shirt, the pants, and the belt. They are all connected when you start, and you will separate them as you place the dressing. The shirt is the center of the dressing, and the largest piece. It contains a transparent window in the center surrounded by a more rigid material, and at the bottom of it is a slit. The window should cover the access site completely. You should be able to view the insertion site and the catheter hub easily. Place the shirt positioned to show this, and make sure the slit is pointed down the arm in the same direction as the extension tubing. Gently lay the shirt over the access site. Do not stretch it tight as you place the dressing, because this will put unnecessary pressure on the catheter that can lead to the development of pressure injury. Just lay it over the site, and push it down with your hands to make sure it fully adheres to the skin. The extension tubing should line up with the slit at the bottom of the shirt. Once it is in position, push the 2 pieces of the slit down onto the skin so that the extension tubing is left exiting the dressing from the small hole created about 3/4 of an inch from the edge. Remove the paper frame from the shirt. This will separate the pants and the belt from the shirt. Next, we'll put on the pants. They are made of the same material as the outside piece of the shirt. It is more durable than the transparent window. There is a small U-shaped opening on the pants, and there are also 2 paper tabs on the corners that remain after you peel it away from the paper frame. These are there for you to hold and to avoid the pants sticking to your gloves. You're going to tuck the shirt into the pants, which means the pants will overlap the bottom of the shirt piece. Lift the extension tubing and slide the pants so that the U-shaped opening surrounds the extension tubing, similar to how the tubing sat between the opening of the slit on the shirt. Smooth the pants down, and then remove the paper corners, and gently press the pants down completely. At this point, you should close the slide clamp over the extension tubing. Whenever the IV is not in use, the slide clamp should be closed. With the saline syringe still attached, slide the clamp so that the tubing is pinched and occluded. This is often ignored or skipped, and it will lead to clotting off of the end of the IV in the vein, and ultimately a decreased lifespan of the IV. If you don't close the clamp, when you remove the syringe from the port, it will create a small amount of negative pressure in the catheter, because the space occupied by the tip of the syringe will be backfilled by saline. At the end of the catheter that is in the blood, this will cause a concave opening to form as the saline retracts into the catheter. This opening will be filled with blood. That blood will become stagnant as it sits in the opening and no longer flows with the current of blood. It won't take long for that blood to begin to clot, which can occlude the catheter and make it unusable. If before you remove that syringe from the end of the IV, you slide the clamp closed, you create positive pressure in the IV. This creates a convex protective bubble of saline at the end of the catheter. Blood is not able to sit on the end of the catheter and instead is constantly moving with the flow of blood, which means it never has a chance to clot on the end of the catheter. This leads to significantly extended lifespan of your IV catheter. At this point, you should also apply the swab cap to the end of the extension tubing by firmly pressing it over the port. Anytime the IV port is not connected to a syringe or infusion, all ports should be covered with an orange swab cap. The swab cap contains a sponge impregnated with alcohol that protects the end of the catheter from contamination and bathes it in disinfecting alcohol. Finally, it is time to apply the belt. There is space on this piece to time, date, and initial the dressing, and make sure that you do this at this point. Then place the belt overlapping the shirt and the pants where they meet. The belt can also be used to position and hold the extension tubing so that it is directed up the arm, or you could choose to use tape to position the tubing. When the IV advance is placed correctly, it does an excellent job of protecting the IV from accidental dislodgement. It can be pulled on with a lot of force and still remains in place. Obviously, if someone really wants to pull out their IV, this won't stop them, but it does stop the vast majority of accidents from ruining a good IV. The other dressing option available is the standard Tegaderm dressing. This is a simple, small, transparent adhesive dressing that is commonly used to protect IVs after placement. After your IV is in place, peel the backing off the Tegaderm and lay it over the access site. You want to completely cover the catheter hub and the connection where the extension tubing and the catheter join. Peel off the paper frame from the dressing. There is a label attached to the frame. Time, date, and initial this label and place it directly on the Tegaderm. You'll need tape to further secure and position the IV and tubing. Silk tape and paper tape are stocked in the pod rooms. Paper tape tends to cause less irritation to the skin in some patients, but does not adhere quite as well as the silk tape. Tape also comes in different widths, and silk tape is easily torn in half to get to your desired width. I personally prefer to use thinner strips of tape for my dressings. One common practice is to prep the tape before applying the dressing and stick it to a nearby table or bed rail until you need it. This is not best practice. It introduces a potential infection risk to the insertion site you just created. Tape is sticky, and by prepping in this way, it is stuck to a non-sterile, probably dirty surface, and then carried over and applied very near to a hole in the skin that gives direct access to a vein. Infections can lead to a loss of IV access, and that's really a best-case scenario because infections that have a direct line to a vein can quickly lead to life-threatening issues. So unroll your tape as you need it, and use it to secure and position your catheter's tubing. Most people will place a strip of tape along the bottom of the Tegaderm, and then at least one more to position the tubing so it's pointing up the arm. This position can help protect your IV, because if the IV tubing is attached and gets pulled on, it won't be pulling the catheter straight out of the arm, but will instead be pulling in the opposite direction. When you're satisfied with your tape, flush the catheter, close the slide clamp, detach the flush, and apply a swab cap. The standard Tegaderm does little to secure the IV, which is why the IV Advanced is such a useful tool to have. Pulling on the IV Advanced requires a lot of force to dislodge the catheter from the arm, but it doesn't take as much effort to lose access with a standard Tegaderm. With the IV in place, and the dressing protecting it, you have successfully completed the IV insertion. Chart your IV placement in Epic using the avatar. So how long can it stay in? At Trinity Health Livonia, an IV can stay in place as long as it is free from signs of infection and it is still functioning properly. If you take care of an IV, flushing regularly, and always closing the slide clamp, IVs can last weeks. However, the dressing will need to be changed more regularly. If it ever becomes soiled or is starting to peel up, it should be replaced. It also must be replaced at least every 7 days. This is why timing and dating the dressing is so important. If you can't figure out when a dressing was placed, it needs to be replaced during your shift, and make sure you time and date the new dressing and chart the dressing change in Epic. Put all the used catheters in the sharps container. All other garbage can be in the trash or biohazard bin. The placement of IVs is something that will need to be completed for most patients at Trinity Health Livonia. It can't be done by PCTs and RNs. It is a skill that requires practice, so take the opportunities when they come, and don't be discouraged by failed attempts. Learn from them. Get better with every attempt, and eventually you will master the skill. It will save you time and hassle, and your patients will appreciate your dedication.
Dressings are to be changed every 7 days and as necessary when wet, loose, or soiled, utilizing a standard central line dressing kit. This is because the size of the device is larger than a traditional IV and requires a larger dressing. Using clean technique, remove the occlusive dressing. Using aseptic technique, don sterile gloves and remove the disc or gel patch, and after swabbing with alcohol at the wings, remove the stat lock device. Cleanse the site with chlorhexidine impregnated swabs and let dry. Use skin prep and reapply the stat lock device. Place a disc or gel patch and then place an occlusive dressing over the insertion site, covering both the site and the disc. Place a sticker with the type of device, date, time, and initials on the dressing, and then document the procedure in the electronic chart. Every 12 hours, the midline catheter site should be assessed for patency, redness, irritation, and/or discomfort to the patient. Flushing and assessment for blood return should be performed and documented. Removal should be performed when therapy is completed unless otherwise indicated. Midline catheters should be removed if swelling, redness, irritation, or complaint of patient discomfort occurs. Before you attempt to remove the line, you need to know how long the line is. At our facility, this information can be found under the Mini Assessment Midline Insertion section in ClinDoc. You should gently remove the dressing and the stat lock device from the site using clean technique. Be sure to gently remove the catheter and observe that the catheter is intact. Use manual pressure to assure hemostasis has been obtained. Place a gauze dressing to the site and then document the procedure in the electronic chart. If the line is clotted with blood due to improper maintenance, you can administer 2 milligrams of CathFlow IV push to the midline in an effort to dissolve blood in the line. Do not forward flush with saline. Only let the CathFlow dwell in the line, then try to aspirate it. If unable to aspirate with a 3 milliliter syringe, have the line removed or contact the vascular access team. In terms of monitoring, the vascular access team has and will be recording all relevant line placement data. In regards to midlines, we are recording how many attempts, successful placements, failed placements, and how many each member of the team is doing per month. Additionally, we are now recording improper orders leading to delays in treatment, improper callouts, and traditional IV starts that are requested by staff. If you request an IV be started by the vascular access team, they will inquire into how many times you have attempted the line, if a midline may be warranted, and the status of the patient. If they place this traditional IV for you and have determined that you have not made an effort to place a line despite saying otherwise, they have been instructed to report your name to your manager and to float time to your department. Thank you for watching. If you enjoyed this content, consider liking the video. Leave us feedback in the form of a comment if you have any questions, concerns, complaints, or compliments. If you want to see more content like this, consider subscribing to see more footage like this. Till next time, stay safe.